Hello. Next, we have Dr. Sonu Goel. He'll be speaking on outstanding rotational stability with textured haptic surface. Dr. Sonu Goel.
So thanks AIOS, Dr. Namrata Sharma. Thanks Hoya for making me this part of this wonderful concept of deferred life surgery. So here I'll be showcasing surgery for this 60-year-old teacher, and in fact she's one of the school teachers. She drives, she's fond of reading, and she plays occasional snooker. So actually she wants vision at all three places. So essentially we routinely in our all patients do all these checkups, right from the vision assessments, the keratometry, the IOL power. So power essentially here is 19 with a cylinder of 1.26 minus at 15 degrees. We did the Tracy, the angle alpha, angle kappa less than 0.2, specular 2798, fundus being normal, pressures, and the LipiView, the lipid layer thickness 70. So this is the 700, which essentially gives you the calculation for the cylinder, and this is the specular, and this is the eye trace. We actually look in for all these premium patients for angle alpha and kappa, do a quick LipiView, and all those patients where we find the LLT to be less than 100, we actually subject these patients to a quick warm compressions, azithral, and the treatment for ocular surface. Call these patients 15 days back, do again an IOL master, and just see whether the ocular surface is good enough, and then subsequently take these patients for these premium IOL positions. So OCT, yes, subtle lesions can be missed. So actually all of these patients where you are taking these patients premium. So what premium? I mean, for all cataract patients, I think OCT is a must because you tend to miss a lot of these points. So we do the fundus examination, and I think this the wonderful tool with Atlas has given us a overview of the picture. So this is actually what you send these the findings to the Hoya guys. They will give you this picture. So here we are looking at the model of geometry, which is a T2 model plus 19 and to be positioned at 114 degrees. So quick surgery.
Good afternoon. Welcome you all to this wonderful Hoya session. And I'll be showcasing.
So this is we under topical. I take this patient. I do 2 side port 1.1. I use phenocaine because this gives me analgesia as well as pupillary dilatation. Push in viscoelastic HPMC. So I stabilize the globe. Either use a Kuglins or a McPherson on the left side and try with this 26. So people who are young in training here, I would just always emphasize the role of capsular rhexis, because whenever you're dealing with premium patients, I think a good well-centered rhexis and appropriate sized rhexis is essential, because that is very important to give you that shrink wrap effect, and that is what actually transforms to a good ELP. Because cataract, whenever you are dealing with these patients, whenever you're doing a 700, whenever you're taking care of the ocular surface, you are basically targeting total emmetropic correction post surgery, because that is what essentially gives you that crisp vision what the patient would need for both distance, intermediate, and near. So a quick watch carefully. I go underneath the anterior capsule, push in the fluid wave, and this fluid wave, the stream that you observe is very, very important, because this actually gives you a fair idea that all 360 degrees you have separated the lens from the capsule, and push in a small viscoelastic, and I'm using the Johnson & Johnson Pro here, and the bottle height is 50. So what is more important is that the right hand should always remain stable. I do a straight direct chop, and most of the times it is my left hand which is going to move, and the right hand is just to bury, hold, and the left hand do most of the times the separation laterally. I would try and separate all 360 degrees pieces so that the pieces can be separated, and then gently you can actually emulsify these pieces one by one. So the settings that I would show here are close to the vacuum that I'm using is 400, flow rate of 30, and what is more important is if you see the bottle height, with the Pro system we have actually boiled down from almost a bottle height of 80 to close to 50. Now this gives you a good chamber stability, but at the same time it helps in taking care of the endothelium, and at the same time an appropriate pressure within the anterior chamber. chamber where the compromised nerves in glaucomatous patients is usually spared. So a quick phacoemulsification being done here, and I use bimanual system, and because this gives me a 360-degree separation, gives me a good hold of the globe on either sides, and I'm able to sweep all 360 degrees, and the subincisional cortex is never a problem. The sandblasted system on this also helps me to simultaneously polish the posterior capsule and under surface of the anterior capsule in most of these patients. So quick jet of BSS can actually help in removing those lens fibers on the posterior capsule, and most of these times I would use this sandblasted instrument which has a flow on the top to just snugly sit on the posterior capsule and do away with the fibers, the lens fibers, and just make this surface so shiny so that there is hardly any scope of PCO. And because this is actually what needs to be done in most of these premium patients, so viscoelastic next goes in. The plan is geometry here, and I think the concept of Hoya of getting this concept of paired approach is this is how the injector system looks like. So this is a T2 model. There are 3 steps to it. People who have not used, so this is the marking. There are 3 markings labeled as 1, 2, 3. The step number 1 is pushing the viscoelastic from this small nozzle here, and this viscoelastic goes and bathes around the implant. The second would be just holding onto the clip and removing this clip, and third would be forwarding the lens so that it gets folded inside the delivery system. So you gradually remove this from the holder, and the beauty of the system, as has been discussed, is both you can have a shooter as well as a screw kind of injector. A point to be highlighted here is the nozzle system here. The length of this nozzle can be adjusted. So most of the times you can have either a combination of a wound assisted system, or if the nozzle you prefer to be long, you can have those lenses getting directly delivered inside the bag. Now that's an actual aid whenever I am dealing with patients with small pupils and patients with when the pupil gets shut down. So actually it gives me a good delivery within the bag. So just watch carefully. I use this and the lens almost goes and delivers inside the bag, and there is hardly any manipulation within anterior chamber. I'll just like to showcase here the textured haptic with these Hoya lenses. So these are the marking for the toric alignment. The viscoelastic has to be washed very thoroughly and specifically behind the lens. I would just nudge the haptic out of the bag, and I'd like to showcase. So this is how the sandblasted appearance of the Hoya lenses for their toric platform, and this is actually what gives you the additional stability when this lens goes and sits inside the bag and snugly fits within the anterior and the posterior capsule, and this basically bounces or gives you that the rotational stability. So this lens is basically the geometry has a 4-ring segment here. That's the diffractive zone, and beyond it is the refractive zone. So these are the 3 toric alignments, and a combination of geometry and geometric plus. So Hoya has actually played in the lenses with the light distribution. So we have been using Alcon, Restore Plus, or we have been using a mix and match approach, but here the approach has been on the light distribution rather than just 1 minute more on the addition. So the addition, it gives you a near addition of 3.5 and an intermediate of 1.75, but with the geometry it gives you a light distribution of almost 50% for distance, 17 for intermediate, and 20 for near. But if you have a patient, I would always take a patient first on the geometry, try to assess the patient on day 1. If the patient crips for something more than the requirement for near, I would take this patient on the geometric plus, because this gives you a distribution of almost 35% distance and 35% for near. So the patient would be very happy in a combination, and if the patient is quite happy with both distance and intermediate, continue using the geometric in the other eye. So a couple of few patients that we have done, I think the patients have been really very happy with at all the 3 points. So the lens in place, and thank you very much.
Thank you. Before further delay, I would like to invite Dr. Sheetal Brar. She's going to speak on wider range of focus for functional intermediate vision, the IOL to choose.
Just one question to Sonu, what do you think the advantage of this textured haptic surface of this lens?
So I think, sir, this gives you the rotational stability when you're talking of rotations happening in most of the IOL platforms. I think the industry has actually addressed the rotation by making the haptics a little textured, and which actually once the fibrosis happens in the periphery, that gives you that additional the stability, and the lenses are really there where you want actually.
It will be useful for a toric lens platforms much more.
Yeah.
Okay.